to this. Welcome to this webinar on an overview of global CME CPD systems presented by AMEE CPD Committee. Every one of our presenters today is a member of the CPD Committee, and we are thrilled to have you here and sharing these different perspectives from around the world. We have a lot of content to share with you all, so I will say that the slides and bios from each of the presenters will be sent after the presentation. And in addition, there'll be a recording that will be posted on the AMEE webinar archive page, and it will also be linked on the CPD page. It will be free. So if you are not able to attend the entire webinar today, or you want to share with your colleagues, this will be available for you. My name is Kathy Chappell. I'm a secretary of the AMEE CPD Committee, and I will be kicking this off today, but joined by my esteemed colleagues from the committee and around the world. And again, these are the individual people. Their bios will be shared after the session. So I'm going to turn it over to Lawrence Sherman, who's going to be kicking off our opening and doing a real-time needs assessment to learn a little bit more about you. Lawrence?
Thanks, Kathy. Next slide, please.
Yep.
One of the things we're hoping to do is make this about you. We have the information that we prepared to present, but it's really important for us to understand who you are. So I'm going to have a few polling questions after this. But what I'd also like you to do is, if you can type into the chat box for the benefit of all of us who are presenting for you, what motivated you to participate in this session and what questions you might have for us to answer as we go through, either during the presentation or during the Q&A at the end. But feel free to use this chat box 100% of the time during this webinar, because I'll be monitoring it. So please, if you can and if you want to, put in what drove you to participate in this webinar. As you're doing that, next slide, please. We want to get a sense of who you are and where you're from. Now, there's a lot of different ways to ask this question, but we chose to use the WHO regions. And we say, where do you primarily work? What's your primary work location? And so we've divided it into those 6 WHO regions. So get a sense of where you are, look around you. And then Diana, if you could launch the poll, that would be great. And there's already one question in the chat box, so that's good. And I'll keep watching this. And I'm watching these votes grow. We've got a lot of people from the Americas, Europe, Eastern Mediterranean, Southeast Asia. From a time perspective, I'm not surprised that there's nobody yet from Western Pacific, although it was nicely demonstrated in Aqua. And so this is, I assume everybody can see what's happening and the results of the poll. So we'll just end this poll, but we get a sense of there's a lot of people from the Americas and fewer folks from the rest of the world, but Europe and Eastern Mediterranean nicely represented, as well as Southeast Asia. So that's great. Can you go to the next slide, please, Kathy? We also want to understand not just where you are, but who you are. So what's your role in CPD? And we're giving you 4 choices. So do you plan or develop the education? Do you teach the education? Do you regulate or accredit the education? Or are you simply a participant or learner who's interested in more about CPD that they participate in? So you can launch the poll, Diana, and it just helps us to better phrase and frame what we are presenting to you. It's really important to us that we understand. So go ahead and vote. And I see we have, as people are voting, a much nicer split here than we had in the geography. And so everybody's answered. We could end the poll. I'm sorry. Yeah. And so we get a sense of a nice split. Everybody from just a participant, who are the most important people in the education, to those who plan, accredit, and teach. That's fantastic. One more question, and then I'll be quiet till the end. And thank you to those who are using the chat. Just to get a sense of how long you've been in this industry, profession, business, or whatever you like to call it. So if you can open the poll, this is an easy one. No studying required for this one. So vote when you can. Thank you for the people who voted, I'm so new, I can't even spell CPD. I thought that was a funny question. All right, nice split. So there's a nice split between those who have been in it 5 years or less, and those who have been in it 6 years or more, and well represented by the veterans 15 plus years. Those are all my questions. Kathy, next slide, please. And what I'd like to do is ask you to take over and sort of set the framework for the rest of this. Thank you all for participating. I'll be in the chat box.
Great, thank you, Lawrence. So we thought we'd start out with characteristics of CME CPD systems. AMEE, under Lawrence's leadership, has been doing regional assessments of CME CPD systems. And actually several of our presenters participated either as the country representative or the regional representative, looking at sharing about their particular system. And so as we go through the presentation, I wanted to highlight kind of the major characteristics that we would be looking at in terms of a country or a region system. So we look at the regulatory body and of the practice of medicine. So is the regulatory body controlled by the profession of medicine, which I would say is a mature system, or is it controlled by something like a governmental agency? That's a characteristic of a CME or CPD system. Another characteristic is whether there's any type of tracking mechanism to ensure that physicians are engaging in CME or CPD. In some areas of the world, there's absolutely no requirement for you to participate in CME or CPD once you finish medical school. And in other areas, there are much more highly regulated systems that include accountability for participation or tracking in number of hours, number of points, things like that. We look at independence. We look at, is education developed independently from the influence of a commercial interest organization like a pharmaceutical company? In some areas of the world, CME is predominantly provided by pharmaceutical companies, and in other areas of the world, there are strict standards that separate the ability of a pharmaceutical company to have influence over the learner or over the content that the learner is engaging in. When we look at learning science frameworks, is there, like Kirkpatrick, is there a framework by which education is developed in terms of engagement, in terms of measuring learning, impact of learning on practice? Is that embedded within the system? And is education developed based on adult learning principles? We know that children learn differently than adults, and there's a body of evidence around what are adult learning principles that we would want applied in the education that physicians in practice would be pursuing. Wanted to look at the overall quality of education. Do learners feel like education is of high quality, or do they feel like it's meeting their needs? We look at the format of education. So is most education provided in person at conferences, or as a result of the pandemic, a lot of education went digital, and people are engaging from their homes, from their offices in different ways than they had traditionally before. Similar self-assessment. Is there any mechanism by which individual physicians do a self-assessment and identify their own learning gaps? Or is that done at a higher level where a country, for example, a Ministry of Health says, this is what we think physicians in this country need to know, and we're going to push that out, versus a more self-driven model? Is there any evaluation of change? If you participate in CME or CPD, are you recorded as just time sitting in your seat and engaging in a webinar? Or is there any evaluation of knowledge change, ability to apply knowledge in practice, or ways of evaluating change? For interprofessional, we mean members of different professions coming together, learning from, with, and about each other. That's a hallmark, I would say, of a more mature system, as opposed to the individual siloed models where doctors all work together and learn together, nurses are learning together, and they don't often interact. However, we know they all interact in the practice environment, versus interprofessional education, which might bring doctors and nurses and pharmacists and physios together into the educational environment, and they're learning from, with, and about each other. For a team-based issue or an issue that's in patient care that is influenced by the collaboration of the team. We look at faculty development. So if you're teaching in CME or CPD, are there resources for you to learn and develop your skills? That's what AMEE is built on. So critical component of CME CPD systems. And then the last things are the systems accessible and are they affordable to physicians that work in the countries, or I would say as a nurse, to all healthcare professionals who work in that country or region. So with that, those are kind of the major elements or characteristics of CME CPD systems. And I'm going to pass it on to Samar, who's going to talk about the Middle East and North Africa. And each of the presenters is going to be reflecting the characteristics of the CME CPD systems in their regions. Thanks. And I'm going to pass it over to Samar.
Thank you, Kathy. So in the next few slides, I'm going to share briefly with you some perspectives from the MENA region or Middle East and North Africa. Next, please. The MENA region starts for the Middle East and North Africa, and it's sometimes called the WANA region, West Asia and North Africa. It includes 19 countries with around 6% of the world's population. The number of physicians per country per 1,000 people varies from 0.5 to 2.6. Next, please. Across the medical education continuum, there are different models for undergraduate education or postgraduate medical education and the CME CPD. So for example, for the undergraduate academic model, it includes either the dual model, which includes the 4 years pre-med and the 4 years of medical school, or the direct 6 to 7 years post-secondary school plus or minus an internship. Some countries include both models like Lebanon and Qatar. Some only has one model like Egypt and Saudi Arabia, which includes the direct 6 to 7 years post-secondary school. The postgraduate academic model is either the structured, which is based on the competence-based education or outcome-based education, adopting the CAN-MEDS or the ACGME standards, or unstructured, like some systems that are only depending on the duration of residency without a structured format. The CME CPD system, which is our concern today, includes credit systems, accreditation systems, and again, the availability and the maturity differs from one country to another, as we're going to discuss in the next few slides. Next, please. Starting by the CME CPD credit systems, I selected some of the items to highlight in credit systems across the MENA region. First, the terminology. There is an issue in terminology and the CME CPD credit systems and the accreditation. So different countries, different regions use different terminologies. And that's why many big organizations, big institutions and bodies like the International Academy of CPD Accreditation started developing a glossary of terms for the consistency of terminology across the world. One of the confusing terms for the region is the CME versus the CPD. CME stands for continuous medical education. CPD stands for continuous professional development. In many occasions, they are used interchangeably. However, they are not the same. As we can understand, the CME is mainly focusing on medical knowledge. The CPD is a broader concept that encompasses not only medical knowledge, but also professionalism, communication, and research skills. Also, CPD encompasses not only the education for physicians or CME, but also nursing education, CNE, pharmacy educations, CPE, and other education for other healthcare professionals. Structure of the CPD credit systems varies from one country in the MENA region to the other. It can be structured, which is divided to categories. Categories can be 2 or 3, and they can be categorized according to the activity formats, the educational impact. So, for example, the Qatari accreditation system includes 3 categories. One is the accredited activities, the group accredited activities like the workshops, seminars. The second is for the self-directed learning. The third is the self-assessment activities. In other countries, they are not categorized and they are randomly distributed as just an activity. So it's a workshop, it's a lecture, it's a seminar. The currency of the credit systems are either calculated in hours, or hours are being translated to units and points according to a matrix or an equation. Providers of CME CPD varies again from one country to another, and there can be more than one provider per country, which is mostly the case. So providers are either governmental or private, and this can be healthcare provider organizations or hospitals. They can be academic institutions, and many of the universities have their own department for CME CPD nowadays. And there can also be professional associations that provide CME CPD. Requirements of CME CPD varies again from one country to the other in the MENA region, and many of the countries are mandating CME CPD for licensure nowadays, mainly in the Middle East. This is still not happening in North Africa, like in Algeria and Morocco. There are some institutional requirements. For example, there are some institutions that mandate CME CPD for promotion, especially academic institutions. And in other countries like the North African arm of the MENA region, it's still voluntary, which is with some incentives to attend the activities, but no mandatory requirements. Tracking is variable, so if it is voluntary and if it is not mandated, there is no tracking, and physicians can maintain their certificates of attendance for their own usage or for institutional requirements for promotion and other reasons. There can be manual documentation, so physicians and healthcare professionals can maintain a manual portfolio, and this can be submitted to the regulator or the licensing body if required. The well-established system have their own electronic portfolio system or platform for submission that is linked to the licensing requirements and the licensure process in order to translate it to the requirements for licensure and automatically renew or suspend the license. According to the review that was done by Lawrence and the team to review what is available and the funding in the region, so there are different formats and there are different availability. Some are the traditional formats, the didactic formats, but mostly many of the CME CPD providers are moving to the more innovative formats and the virtual formats, especially with the era of the COVID. There is a problem with funding, and it's mostly lacking, whether the financial funds or the protected time that is required for CME CPD attendance. Next, please. CPD accreditation systems, again, are different from one country to the other. So they are either non-existing, like in Algeria and Morocco. They are sometimes evolving in some countries. So they have started, for example, activity accreditation, and they are moving to a more robust provider-based accreditation system. Or some countries, they have an established or a mature accreditation system. Types of accreditation system are either activity-based, where individual activities are being accredited, provider-based, where institutions are being accredited and they are allowed to accredit their own activities, or the hybrid model, where both types of accreditation are available. Responsible parties for accreditation are either governmental independent or part of the ministries of health. Sometimes professional associations are responsible for accreditation of CME CPD activities. Standards of accreditation are mostly adopted from the best practice and well-established systems. So they include educational standards that are concerned with the planning, evaluation of education, administrative standards that include things like running the CME CPD unit, and ethical that is mainly concerned about the conflict of interest and the independence from pharmaceutical industry. The process of accreditation varies again according to the maturity of system. It can be a simple review process, reviewing some documents, or structured accreditation cycle with a fully governed process with self-study, site visits, and a monitoring process. Monitoring can be mid-cycle reviews, participants' feedback, and program evaluation. Next, please. Systems are very keen to align with best practices. So mostly the well-established systems and the evolving ones are adopting the standards from the best practice, mostly the ACCME and the Royal College of Physician Surgeons in Canada standards. They are also moving to the concept of substantial equivalency, which is again something that is introduced by the International Academy of CPD Accreditation and is based on recognizing accreditation systems across the globe based on common principles. Not details, but core principles. And example of this is the substantial equivalency agreement signed in Qatar and Oman with the Royal College of Physicians and Surgeons in Canada and the ACCME. Credit exchange policies, again, is concerned about recognizing credits from one country for usage in the other country for renewal of licensure. Accreditation systems or credit systems can maintain a list of bodies that provide CME CPD providers, and they can recognize it in other countries for renewal of licensure purpose. Next, please. Interprofessional education, as Kathy explained, which is based on a team of healthcare professionals learning together, is still evolving, and it is still limited. It's more in simulation activities. In many cases, the awareness is not still there, and physicians are not very supportive of the concept of interprofessional education in many countries. CPD providers need more expertise in the design and delivery, and it's to be understood that interprofessional education is not about a group of professionals sitting in one room and deliver the same content. It depends, it should be relevant to the different healthcare professionals attending the activity. Promoting factors are joint accreditation, which is accreditation of more than one provider for more than one specialty, and mandating the credit requirements across the healthcare professionals, which is not still there in all countries. Next, please.
Samar, we have just about 30 seconds to finish
So
up.
I'm going to finish quickly.
I know we have a lot of content.
The ethical standards, which is the pharmaceutical influence. Again, this is variable from one country to another, but it is to be mentioned that countries are very keen to align with the ACCME standards, which ensures the independence from pharmaceutical influence. Still, pharma can provide CME CPD in some countries. Pharma can sponsor but not provide education in others. And monitoring of the process occurs via usage of feedback from participants and program evaluation. So the last slide, I'm going to leave it for you to read when we share the slides with you. It's just a summary of what I mentioned. Thank you very much. I'm going to hand it over to Alvaro to give us some perspectives on Latin America. Thank you very much.
Thank you, Samar.
Thank you, Samara. Thank you, Kathy. Next slide, please. So Latin America is a very large region with over 20 million income countries and 600 million inhabitants who mainly speak Spanish and Portuguese. And there are approximately 1 million physicians in the region, along with an even larger number of other healthcare professionals. So the Spanish-speaking countries, which is most of them except for Brazil, are quite heterogeneous. And although we share a common language and culture, but however, I mean, each country is a different world, so healthcare systems differ among them, and the CPD systems, of course, depend on the country context. So we're talking about a region, but at the end of the day, each country is a different world. So, by the way, I'm all the way down there in Montevideo, Uruguay, just 2 hours by boat from Buenos Aires. And before we move on, Brazil represents 1/3 of the region by all accounts, and it is less culturally integrated with the rest because of its different language, which is Portuguese, and its size. Next slide, please. So I'm just going to mention some of the main issues here, and you have this for reading afterwards. But basically, CME CPD in the region is largely self-regulated by the profession, and participation is not usually tied for licensure to working to the ability of practice medicine. So physician participation is most often voluntary. Each country may have or not credit systems, and some are used, like in Mexico. Specialists are required to complete 250 to 300 points every 5 years to practice as a specialist, but not to be a physician and practice as a physician. And tracking mechanisms are loose, are not very it's not very they're not very well implemented because licensure is not does not require to practice as a physician. And the last question is mechanisms to ensure independence. It varies across countries, but as Samar said, for the Middle East and North Africa, it happens in Latin America that some countries like Mexico, Peru, or the Dominican Republic, a pharmaceutical component, can even provide CME CPD. So independence is not ensured here. Next slide, please. Regarding education, academic preparation for physicians and for specialists in Latin America is relatively congruent. So it is well formalized. Unlike CME CPD systems. And the overall quality of the education provided in CME and CPD, because systems are in various stages of maturity, they don't necessarily incorporate all the elements in a system for best practices that Kathy mentioned at the beginning of the talk. And the different formats were ranked in the survey that Lawrence talked about and led, and people, I mean, physicians liked online patient-based case learning programs, hands-on learning, online video lectures, answering questions at the end of a learning activity, and attending live regional education activities. And you should know that this is a little bit, this was done during the pandemic, so it's probably because of that, so many online activities that people rank on top. So next slide, please. Regarding evaluation and impact, and generally there's no evaluation of change in learning or impact. And generally there is no much interprofessional CPD. And next slide, please. So in summary, there is a significant need to increase standardization, harmonization, and regulation in the current CME CPD systems, like there is in Europe to a certain extent that JP is going to talk about a little bit later. We don't have this in Latin America. There are more opportunities to link participation of CME and CPD to gaps in practice or patient health outcomes. There should be more opportunities for active learning strategies that promote change in practice, as well as interprofessional continuing education. There should be systems of incentives to encourage more physicians to participate, starting that participation in most countries is voluntary, but there should be incentives. And in most countries, pharma and device industry support should be more regulated in order to differentiate marketing from educational activities. And now I turn the floor to Harumi.
Hey, so hello everyone. I'm Harumi Gomi from Japan. I'd like to present the data for Asian Pacific regions. Next slide, please. So this is the summary slide showing the geographic region. And as you can see, this is a summary table showing the population for each country and the number of physicians per 1,000 population. My presentation does not include Australia and New Zealand. primarily focusing on East Asia and Southern East Asian countries. And as you can see, most of the countries, the number of physicians are less than the average of the ones of OECD at 29 countries. Singapore and Japan, we have a little bit lower than the average, but as you can see, most of the countries, Indonesia and Thailand, those countries need a significant development for medical doctors. Next slide, please. And I'd like to share the regulatory organizations, and then if it's mandatory or not, and then credit systems. For most of the countries, either a government or academic associations regulates the CPD or CME systems. And if it's tied with medical licensure or not, excluding Japan and Thailand in this table, are mandatory for medical licensure. In my country, Japan, CPD and CME are not required for medical licensure renewal, but only mandatory for the board certification. In Thailand, CPD and CME is not mandatory. And for credit systems, most of the countries have been using the sliding scale by activities. Next slide, please. And then what kind of formats have been used and mode of delivery? Most of the countries have been using the format of either pre-approved or formal or congress or symposium or workshops. And then some of the countries have been using the in-hospital journal clubs or self-learning. And a mode of delivery, either in person or online, especially during the period of COVID-19 pandemic. And then for assessment systems, I can provide only the data for Japan. In Japan, we have been using the self-assessment quizzes after the each lectures or academic activities. And this is the data I all have. Okay, next slide, please. What about the interprofessional education in CPD and opportunities for improvement? In this region, most of countries do not implement or do not provide interprofessional education for a CPD. And for opportunities for improvement, each country has different unique opportunities for improvement. For example, Hong Kong, the survey indicated that more personalized learning to meet needs and team-based learning needs to be implemented. And for Indonesia, access should be improved. And for Japan, it may be necessary to tie it with the medical licensure in the future, but there are significant opinions against it. And for Malaysia, meet the social needs and funding issues. And for Philippines, assessment should be standardized. And Singapore, quality improvement initiatives to improve patient safety and outcomes. And for Taiwan, increased structure for CPD systems and possibly mentorship systems need to be implemented. And for Thailand, not provided. Next slide, please. And this is the summary of this region. So that the number of physicians per 1,000 population in this region is less than the average among the OECD 29 countries. And each country has mostly mandatory CME and CPD systems, mostly tied with the medical licensure or certification. And access need to be improved for some country with funding. And team-based learning and or interprofessional education should be officially implemented as CPD or CME in this region. So this is then, thank you very much. And I'd like to over to Juha, Europe. Thank you.
Thank you, Harumi. This is Helsinki calling from Finland. Can I have the next slide? There has been a lot of discussion about the puzzles between the areas. So the countries are very different from each other. And this is also what you see at the European map. In this map, this demonstrated the requirements for medical doctors. Is CPD obligatory or voluntary? Or if it is obligatory, are there sanctions or are there no sanctions? However, the European data that has been gathering, it's going to be gathered the 2020. It is just in the beginning of the gathering phase, so we don't have that as we show it on the other continents. However, we know that although there are requirements for movements of European doctors at the European between European countries, so it's also reflecting how you can how the CPD is required depends on where are you working. So if you are a Finnish doctor and go to United Kingdom, you have to apply the United Kingdom requirements. There can also be a lot of requirements for languages in each country, so that's one part of that. However, there are some very strictly regulated CPD countries like UK and some quite liberal like the light green ones, light green ones like Sweden and Finland. And when I talk about our country, our situation, it seems at the moment there's a lot of debate about the resources. Are the resources enough? There are recommendations in many European countries that you should have a certain amount of external and internal education. And for example, in Finland, it's between 4 and 10 days a year to get external CPD. There has been data gathering. Normally, the Finnish doctors, they report they get about 8 days a year, but in the first COVID year 2020, it was diminished to about 5 days during every year. The pedagogical tools that we have been discussing with the other continents, they are recommended, but their use is not optimal. We know that there's a lot of requirements, but the working conditions in hospitals and health centers, I think they are also very difficult sometimes because you have to work so much. We've discussed a lot about the lack of documentation, planning, feedback, and evaluation. And it has also been lately more emphasis for the single doctor, how he or she is going to maintain his or her CPD, but it's going to be also very important to talk about the responsibility of the hospitals and health centers and employers, that they can have good working discussion and working conditions. And evaluation of national systems will give us important information in the future. Can I have the next slide? In Europe, there are also international standards that I think could be important for especially those who are not from Europe. So here we have European Accreditation Council for continuing medical education. The website first page. The next slide, please. There is a specialist organization for European de Médecins Specialist established 1958, and it contains medical associations from European countries, And it also has sections for specialist societies, sections and boards. So there's a lot of medical expertise there. And that UN has established this European Council, Accreditation Council, AMEE 2000. And it means there are plenty of agreements in Europe between this Accreditation Council and countries, but also between Europe, America, means USA and Canada. And I think there's going to be also new agreements with Latin America. Next slide. So in this international system, it means that if you are a doctor and you are going for a congress from Europe, for example, from Finland to Boston, when we have the agreement, we can use that Boston Congress to our CPD in Finland. So that's, in that sense, it's a lot of importance. There's a currency unit called ECMEC. It means about 1 hour. And there have been several steps. We see the history. 2009, e-learning materials were included. After that, new forms of CME and CPD activities. And there's an electronic system for platforming for accreditation. So there's you are asking for accreditation for meetings, and they will be certified and studied by AMEE and also the specialist societies and also the country where the Congress is going to be held. So there's a lot of accreditation process. The next one. And those international forms are here, as you can see: live events, e-learning materials, journals, and webinars. The next one. And you all know these COVID years have increased these webinar packages, and that has caused a lot of new technologies and also a lot of new possibilities to develop CPD globally. So even this is possible today here with this webinar. Can I have the next one? And there's also another other line. The general practitioners have their own European organization, and they have also established this accreditation board for European general practitioners. So we can see this kind of movement and new formats for international things. Can I have the next one? So that was the part of my talk.
Perfect transition, JP. Thank you so much.
Yes. So Kathy, please.
Yep. Thank you. And I'd ask all of our panelists to go ahead and turn on your cameras, and Lawrence is going to facilitate some of the chat. I think I understand we have a question in the Q&A that might need a little expansion, but before we get to that, because we absolutely want to hear from you, just, kind of in summary, I think when you heard each of the presenters, you saw really a tremendous amount of variation in CME and CPD systems, from some that are highly structured, very regulated, to some that have absolutely no regulation at all. And, that's certainly expected in some ways, but it's what the AMEE CPD Committee is working to develop this community of practice and share this kind of information across and be able to support each other. Country context really impacting. I know Alvaro and I talked about, there are areas in Latin America where geographically it's so difficult for physicians, doctors in remote areas to get to an urban location and participate in an in-person conference, that our ability to be able to get education out to those physicians and other healthcare practitioners in rural areas is important. And certainly the political environment from each country is going to impact the CPDs and CME systems. saw different types of maturity. We do have certainly doctors and other healthcare professionals. They are engaged. We know they've been successful academically. They've completed their medical school or nursing school, and they're successful. And so we know they can learn. We just need to bring the CPD system to them. And I think it's time, you know, possibly spurred on by the COVID pandemic, for some change in the right direction. So with that, I'm going to move to just sharing the members of our CPD committee and the areas of the world that they represent, our mission and goals, and our website is here. And Lawrence, I'm going to turn it over to you to share with us what's happening in the chat and any questions that the panel members might be able to answer.
Sure, thank you. And thank you, everybody. You did such a great job. And I know some of it had to do with data that you didn't collect, but were asked to present. And some, like JP, were asked to present before the data were available. So you all did a phenomenal job. I will say the results of all of this research, of all of the regional assessments, will be published as an open access supplement to medical teachers sometime in the beginning of 2023. And there'll be data individually on over 50 countries, and then there'll be an assessment and a comparison, contrasting of the systems in these different places. And we are thinking about additional system assessments as well. So just a few things. So I know that there was a question in the Q&A, and Tara asked this question, and Tara, you also asked a question at the very beginning. So thank you for using both of the tools available to you. So Tara's first question at the beginning of the session was, she was interested in knowing why do all the document every year of all of their activities. And so my question to you, Tara, is you can either turn on your mic and your camera or type into the chat. Tell us where you're located, because these requirements differ based on geography, and there are fewer requirements in places and no requirements in other places. So we'll need to know that. While you're doing that, the other question she had, which I think is a really interesting one, is how effective are the systems that monitor CPD, CME for different educational institutions and use their performance in biometrical rankings? So okay, so you're in Erbil. Thank you, Tara. So when you're talking about, number one, the documentation requirement, are you talking individual documentation or documentation of by the providers who have to submit it to some regulatory authority? And we've not yet assessed the systems in Iraq, so I don't have that comparative data to speak like that. But we'd like to be able to answer these questions. So are you talking
thank you, sir.
Yeah.
Thank you for the question, sir. No,
Please.
my question was pure generally speaking. Why do we just get ourselves busy every year with all the documentation process and how we collect? And I'm just generally asking about what the documentation is about. So thank you.
Sure. And Kathy, do you want to jump in on that one?
Yeah, I think I would say, some areas there's absolutely no documentation. I'm not sure what's required in your system. Some of it is just administratively. Is it easier for example, for nurses who are certified, we collect that documentation every 5 years to validate that you've been engaged in lifelong learning over your period of certification. So we don't require somebody to do that every year. We require them to submit that evidence every 5 years. My guess is that some structures just find it easier to collect that data on an annual basis so that they can ensure that somebody doesn't wait for 4.5 years and then to try and do everything at once, but that they're actively engaged in education, and whoever the administrative person is that's monitoring that and giving feedback, et cetera, wants to do it on a more continuous basis. What is the system, Tara, that is it that every year you have to document what you've done in that year?
Yes, ma'am. That's what we do every year. In fact, in this very month, we have to make sure that everything is piled up and ready to be uploaded to our portfolios. We have a learning management system that has a special place for all the documents to be collected digitally.
Right. Yeah. I'm not sure of the other panelists what your systems are like, if it's on an annual basis or kind of a periodic basis. I'm giving you a US perspective on that.
So Kathy, if you allow me, so I think it's, as you mentioned, it varies from one country or one system to the other. So if there are some mandates for collecting credits, and this is linked to renewal of licensure, it depends on the licensure cycle. So some licensing authorities renew licensing on a yearly basis, on every 3 years or every 5 years. Some countries are not having a renewal process so far, so they have it for life. And so it varies. And as you said, many of the countries are encouraging the submission of the collection on yearly basis, so that they are not encountered by the fact that they have not collected enough credits by the very end of the cycle. So they are aware that they are lacking in this category or in this area, and they remediate this before the renewal date.
And Kathy, I think Alvaro has a comment.
Yeah.
Yes. So hearing all the presentations and the questions, there are a lot of things that have been done in the countries and regions, and many things that would like to be done, or best practices. And what will be the journey for that? That's a question for each of us in our role in each of the countries. That's a question. And we had a very interesting experience in Uruguay, which is a very small country. I mean, it's easier, might be easier. And one of the things that we did was to try to understand the best practices, as we're trying to share here in this webinar. And we had a collaboration with the Spanish government, and also with the US and Canadian accreditation systems. So we did a lot of benchmarking to try to understand what are the best practices. And then there's the political process that, because of the many stakeholders in CME and CPD, you have to have most people on board and move forward. I mean, the academic institutions, professional societies, professional bodies, and the government, etc., etc. And you have to move them forward together and to advance. And third, you don't want just a new bureaucracy with this. You want really something that impacts healthcare practice and learning of physicians and teams and other healthcare professionals and teams. So you have to keep that in mind, so that you don't just put a new bureaucracy on top of everything else. That was my reflection.
Alvaro, I think, oh, I'm sorry, Lawrence, go ahead.
No, go ahead, Kathy.
Oh, I was just going to say, I think, Alvaro, you hit on, we don't want this to be a checkbox exercise, right? We don't want you to just sit in the chair and check a box and say that you met the requirement. The goal for any of these systems is to have healthcare professionals engaged in education that's meaningful, that has a positive impact on practice. And the credit system or recording it is just the method by which they ensure engagement.
Yeah, and I'd like to sort of make a comment on top of that. So I think, first of all, a big reason that Tara had to ask the question that she asked is, in many cases, we're finding around the world that healthcare professionals are not being prepared during their undergraduate, postgraduate training to be lifelong learners. So then often what's imposed upon them feels more like a burden than part of their professional commitment. And when you see that, I mean, you all did such a great job of articulating where it's voluntary or mandatory, where there are sanctions or no sanctions. So it's mandatory, but no sanctions is like being voluntary. And so people have to prioritize what they do with the time, and whether they're given time, like JP articulated, where there's a set amount of time that they have, and sometimes it's expanded so that they can do their education. If there's not enough time and it's not required, and they weren't prepared to be lifelong learners, there are healthcare professionals around the world that don't have 1 minute more of education after they graduate. And so I think part of what we have to do is advocate for being part of that continuum of health professions education in the places that continuing education isn't. And then I think we're preparing people to be better lifelong learners. And there's people all along that bell-shaped curve, people who don't want to participate to people who thrive because they can participate in that ongoing education. There's another question. Yusuf asked the question, I'm wondering what you think about the future of accreditation rules for online learning, e-learning, and do you think there should be some distinction in the accreditation rules for in-person and online? And I know we've talked about this for years. I'm going to say, Samar, is this something you'd like to make a comment on? Because I know we've talked about this. You have to unmute.
Yeah, so thank you for the question. I think there would be lots of change in the future of accreditation rules for online and e-learning activities, given that we are moving towards virtual learning. And I think we are not going even after the COVID crisis, and I hope that it is now coming towards an end. I think we are not going to go back to what we were doing before the COVID. It is proof that the virtual activities can be as good as the physical ones, provided that we are doing the right format of planning and delivery. So for the distinction between the accreditation rules in person and online, there would be definitely distinctions, and there will be differences, because the planning and the evaluation and the design are different in both of them. So accreditation is about quality and about educational standards, as we mentioned. And there are some, and so the administrative standards, the educational standards, and the ethical standards would differ from this one to that one. And I think it should be more robust and online, because there is an opportunity of laxity in the online compared to the physical ones.
That's great. Alvaro, I know you spend a lot of time in the e-learning space. Do you have any thoughts on this, sort of comparing and contrasting?
Yes, it's interesting to mention that, because as I said during my part of the talk, Latin America, for example, we basically can do activities across the region. It's a very large region in 2 languages. So it's much easier than in Europe, for example, where you need a common language to speak, which is mostly not your own language, native language. So yes, there are great opportunities to do engaging activity and sequential activities online, and you know how to travel. So the cost structures are different, and you can leverage size. So each individual participating has a much lower cost, and this was a concern from one of the from here, from Farhan, as you about how to take these experiences for low and middle income regions.
Yeah, so JP, you know, given that you talked a bit about EAC CME as well as in-country education, what are your thoughts on the differences between accreditation standards for e-learning versus more face-to-face education? I know EAC CME looks at them slightly differently and has some different criteria for them. What are your thoughts on this?
Now I'm probably online. So I think it's important actually to use the same pedagogical principles for e-learning, like live events. It's actually not so different at the moment. When we are making these hybrids, we actually understand that they are closely resembling each other, I think. And so if you think about these webinar kind of things, the other thing is when you are mostly, for example, for literal or journals or something like that. So I think the pattern is changing all the time, and we are mixing all these things. The one thing I was just wondering, what is important in the future, and that is not so well done. I don't know, is it anywhere, but actually we could get a lot of information from from the patient data, from our behavior, from the medicines that we use. And actually, we would more gather that information when designing our own personal CPD and what we need. So for the need assessment, I think that's important information.
Yeah, and I think that speaks to the question about the burden or the responsibility of individual documentation as we identify our own individual professional practice gaps. I do think that you brought up a really good point, which is we're using the same foundational educational points when we're developing e-learning or live face-to-face or hybrid or whatever else comes up in the future. And I think something that Kathy and I talk about all the time, accreditation is really a mark of the process and the quality. Did you follow the process of good educational design and development? Did you evaluate it? And is it of high quality? I do think that we have to look at things more appropriately. And to your point, JP, of data, also of the formats that we use. So digital education in shorter form is very effective, but there are some accreditation systems that can't provide credit for that. And so I think that becomes a drawback. And I think you also are able to collect so much more data on digital educational activities than you could with just the face-to-face activities. It provides us with more information for evaluation and ongoing needs assessment. So that it really was a great question. And I do think that it's also about accessibility. Digital is accessible to so many more people. And so I think we need to think about how we remain inclusive there. There was the question in the Q&A, I'm going to go back to it, and anybody that wants to jump in on this can. Tara had also asked, how effective are the systems that monitor CME CPD for different educational institutions and use their performance in biometrical rankings? So basically, comparing, if I'm right, Tara, you're asking comparing institution to institution. It doesn't happen everywhere. So I wonder if anybody wants to jump into that.
I think we'd love to, but I think we're out of time on the time we have with you today. Certainly happy to interact. Please reach out if you have other questions. We will be at the AMEE conference in Lyon, which will be a hybrid conference. So a great role modeling of what the future will look like. I think what we work. Do you think Lawrence will be at 90 minutes or?
Oh, no, I guess it is 60 minutes. I thought it was 90 minutes, which is why I continue to roll on. We have a little flexibility. The webinar doesn't shut off. So I would like to see if anybody wants to answer that question.
Sure.
So does everybody remember the question? It was comparing institution to institution as far as CME and CPD and really ranking them.
Right.
And I think that's really interesting. I know, I don't think we do that in North America at all. But Tara, it seems that the system that you're in is very sophisticated. I don't know enough about it to comment, but it seems very good. And I wonder, anybody else on the panel want to jump in about that with experience? I don't know, Samar or Alvaro, Harumi.
Harumi,
yeah. Well, personally, I don't see the systems before. I didn't see the systems before, so I cannot comment on that. But okay. It might be interesting.
Yeah, I think benchmarking institutions would be very interesting in many places. And I think it happens in undergraduate and postgraduate, but I think it happens far less frequently in CPD. Farhan just also asked a question, how can we control the quality of digital events? Anybody want to jump in on that? And we'll make this our last question before we let people go to sleep like Harumi, go to lunch like us, you know, the time zone.
I would jump in just to say that as well as with the live events, the quality has to be controlled, but it's much easier to control quality of online events because you have a digital track of everything. Participation, completion, and everything. So if you compare to a live event, you have much more data to do that. So the question is, when you just try to, as JP said, to do something that you did live exactly the same way online, that doesn't work. That's why the AMEE conference is hybrid, but the participation for those remote will have a different feeling that for those who attend, because it's different.
Yeah, and I also think that requires some faculty training and development. And I'm going to say, Diana, if it's okay with you, somebody raised their hand. And Syed, let's give you the last question, because I want everybody to be able to get their questions answered if possible. So I see your hand, Syed. Put on your mic and ask your question. Or type it. Well, we may have to follow up with Syed. So Kathy, I'll turn it back to you. Panelists, thank you all. You're all my friends, and it's so good to see all of you, and thank you for all participating.
Absolutely. Absolutely, and thank you for joining us today again. We have the CPD committee of AMEE. We also have a special interest group, and anybody is welcome to join the special interest group. We have a liaison from the CPD committee. We have members from the special interest group participating on different task forces. It really is a community of practice, and we encourage you to engage. So with that, we will sign off, and from behalf of all of us, thank you and have a great day wherever you are. Bye-bye.